Welcome. My name is Latasha Scott. I am part of the member engagement team here at Partners. Thank you for joining us today for our monthly Partners Member Cafe. Also joining us from member engagement is Beth Brooks, our behind-the-scenes Zoom guru and question moderator, as well as Kimberly Lambert, who will be entering information into the chat, and our host, Stacia Bonner. Today's topic is minority mental health. Before we begin today's session, let's go over a few housekeeping items. We are offering today's session in closed caption. If you do not need this feature, at the bottom of your screen, you can simply hover over live transcript and click hide subtitles. This meeting is being recorded. Please do not share any sensitive personal information during the session. Partner staff is available for individual issues you may want to discuss. We will share contact information later in our presentation. The recording of this session will be available on our website, www.partnersbhm.org. Under Members tab, select Events and Training. We will also be sending you a follow-up email with the slides. Let's take a look at the Zoom features located at the bottom of the screen. The chat feature is disabled for the session. Q&A is open for you to answer questions as information is being presented. We will moderate questions at the end. The reaction feature is available to raise your hand, and we will open your mic for questions and comments during the Q&A portion. Before I introduce our first guest speaker, I want to share the Taylor Plan will be launching on July 1st. So many things need to happen before it launches, but let's take a quick look at the timeline. Starting from the left side, on April 13th, Taylor Plan auto enrollment begins. That means that the state will begin automatically enrolling Medicaid members that meet the criteria for Taylor Plan. On April 17th, letters will be mailed out, letting members know that they have been enrolled in Taylor Plan. All Taylor Plan members will need to choose their primary care provider between April 15th and May 15th. Members can use the online form or call Partners Access Member Services. The online form is located on Partners' website or in Partners' member portal, Member Connect. On May 16th, the state will automatically assign primary care providers if the member has not made a selection. On May 17th, members can begin scheduling transportation to medical appointments that will occur after July 1st. As you know, Taylor Care Management made a soft launch in December of 2022. Automatic assignments will begin on May 23rd for Taylor Care members who do not currently have Taylor Care managers. Members can make changes to the auto assignments by contacting Partners. Member ID cards and welcome packets will be mailed to members between May 23rd and June 7th. On June 1st, the nurse advice line and the pharmacy line will go live. If you have questions, please enter them in the Q&A and we will address them after our guest speakers. Let me introduce our first guest speaker, Brittany Ragland from the Department of Veterans Affairs.
Good afternoon. Thank you for having me today. I'm going to touch a little bit on mental health in tribal communities. A little bit more about me. My name is Brittany Ragland. I'm a member of the Lumbee tribe of North Carolina, and I was born and raised in Robeson County. I'm a licensed clinical social worker and a certified clinical supervisor in North Carolina, and I currently work at the Department of Veteran Affairs in Fayetteville as a tribal HUD-VASH case manager. So who are the Lumbee? The Lumbee tribe is the largest tribe east of the Mississippi River and the 9th largest tribe in the nation. We're primarily located in Robeson, Cumberland, Scotland, and Hoke County. The Lumbee are named after the Lumber River, which runs throughout Robeson County. The Lumbee tribe became state recognized in 1885, and in 1956, Congress passed the Lumbee Act, which recognized the Lumbee people as being American Indian. However, we were denied benefits of a federally recognized tribe. The Lumbee are descendants of 3 native-speaking peoples who settled in the swamps along the Lumber River in southeastern North Carolina in the 1700s. Today, many Lumbee remain in Robeson County. This county is one of North Carolina's poorest counties, with more than 70% of children living below the poverty line. Unemployment is 40% higher than the state's average. Robeson County is also the most racially diverse rural U.S. county, with Native Americans making up 39% of its population. Historical trauma. So what is historical trauma? It's the multi-generational experience of emotional and psychological injury experienced by a specific culture, racial, and ethnic group. According to SAMHSA, one of the most familiar examples of historical trauma is that experienced by Native Americans. So I included some examples of historical trauma. Forced removal of children to Indian boarding schools. During this time, Native people were forced to practice new religions, and they were forbidden for using their native languages. The Trail of Tears occurred, which during this time, illness and death took place. Biological welfare. So the smallpox infested blankets that were passed out to Native people. Underfunding housing and healthcare despite treaties promising to provide those. And then there were state laws that prevented some voting rights until 1957. Some current traumas that Native people face today: the missing and murdered Indigenous peoples movement, the Dakota Access Pipeline, deep poverty, and just overall higher crime rates, addiction, poor health outcomes, lack of access to quality education. Native languages are becoming extinct, and poor living conditions on reservations and lack of access to resources, so food deserts, transportation issues, and medical care.
The story of our communities, people and nation starts a long, long time ago. More than 60,000 years, in fact. This was when our culture and our law first started to thrive. We knew who we were and where we belonged. We took care of each other, our land and our waters. We ate food that made us healthy, lived on country and abided by our laws and song lines. Our families, our children were happy, with strong minds and hearts, because they were where they belonged. But then, everything changed.
Colonization came, bringing wars, disease, famine, violence, and the destruction and violation of our cultural laws, sacred sites, families, and communities.
We were denied our knowledge, language, ceremonies, and identity, the very things that tell us who we are and where we belong. and our connections with each other and the land grew weak.
And then, our children were taken from us. They had their names changed and their identities stripped away. They were told that Aboriginal people were bad. Worse still, they were told that their parents and grandparents did not want them.
For years this happened, and those children became known as the stolen generations.
Our children were denied love and experienced physical, emotional, and sexual abuse. This left very deep, very complex, and very real wounds, leaving scars that are still being felt personally, socially, spiritually, and collectively.
In the time when our story started, we were able to parent in the cultural way that has seen our families survive and thrive for generations. Our people were strong, and our culture flowed and healed us in times of hurt.
But since the trauma of colonisation and the stolen generations, we have not been able to heal in the same way. And we have unknowingly passed this trauma on to our children through sharing our sad stories and having them witness and experience our pain. This is known as intergenerational trauma, and we see symptoms today in broken relationships, disconnected families, violence, suicide, and drug and alcohol abuse.
But this is not where our story ends. We still have strong minds and hearts, and we still know who we were and where we belong. By creating safe and strong communities together, supporting our families to be free from pain, returning to our culture and building a strength of identity, we can stop the cycle of trauma and bring about positive intergenerational change so that we can continue to thrive for the next 60,000 years. There are simple things that we can all do to help heal our trauma.
Visit healingfoundation.org.au to find out more.
Give me 1 second to get everything switched back over.
And while she's getting things switched back over, I just thought that video was, it just provided a good animation and an explanation of the intergenerational and historical traumas that took place. So as a result of historical trauma, many Native American people, cultures, and traditions have suffered over time. Some observed responses to historical trauma that may include overall poor physical, emotional health, such as low self-esteem, depression, substance misuse, and higher rates of suicide. Native or indigenous people in America report experiencing serious psychological distress 2.5 times more than the general population over a month's time. Although overall suicide rates are similar to those of whites, there are significant differences among certain age groups. The suicide death rate of Native Indigenous people in America between the ages of 15 and 19 is more than double that of non-Hispanic whites. Native Indigenous people in America start to use and abuse alcohol and other drugs at younger ages and at higher rates than all other ethnic groups. Here are some cultural considerations. For various reasons, Native people may be reluctant to seek official help. If an individual is unable to resolve a problem on their own, they'll commonly turn to the following resources in that specific order. So they'll go to family first, extended family, which could be cousins, aunts, uncles. They'll go to their religious leaders, tribal council members, and then mainstream resources. And Native people communicate a great deal through nonverbal gestures, so please be aware of body language when communicating to avoid misinterpretations. Native people may convey truth or difficult messages through humor. So some of the traditions that can be practiced through different tribes are talking or healing circles, powwows, sweat lodges, and smudging. Here are some resources, and this slide will be sent out so you will have access to these resources. Thank you so much.
Thank you, Brittany, for your presentation. I would now like to introduce our next guest speaker, Dr. Simone McIntyre.
Good afternoon. Thank you for the warm welcome, and thank you so much to the other panelists, and most importantly, our members that are joining us today in our community. My name is Dr. Simone McIntyre. I'm the Program Manager at Partners Health Management over AOT and specialty teams. And today I have the privilege of talking with you about minority mental health and how we can work together to break those barriers. So you may be wondering, what are we going to talk about today, and why is it that minority mental health is actually a thing? Is it not just all mental health? So we're going to explore what minority mental health is, the importance of it, and what actually contributes to the disparities within this population. We're also going to highlight the culturally competent mental health care and how we can actively work together to address these disparities within marginalized populations. And then we're going to talk about what individuals can do on a micro or macro level to advocate and find solutions for your community. So as a teenager, I worked in the shoe department at Sears. And during this time, I had to learn about the various parts of shoes, whether the shoe was narrow, wide width, double, or even triple wide. And there are so many different categories when it comes to shoes. You have your flats, your athletics, your loafers, your casual shoes, and then my favorite, you have your heels. So it can be a kitty heel, a pump, or even if you're wild and dangerous, a stiletto heel. And you may say, Simone, what does this have to do with mental health? I want you to understand that just like finding the right pair of shoes, mental health is not a one-size-fits-all fit. So let's talk about exactly what mental health is. Minority mental health specifically refers to the unique mental health experiences and challenges that are faced by many minority groups. This includes racial and ethnic minorities, even LGBTQ+ individuals, immigrants, refugees, and other marginalized communities. These groups often encounter additional stressors such as discrimination, stigma, limited access to culturally competent mental health care that can impact their mental well-being. By being able to address these inequities, we'll be able to understand and address them by intersecting factors to provide inclusive and effective supportive services. So you may be wondering, why is this topic important at all? Well, because the United States population gets more and more diverse every year. Statistics say by 2044, it's projected that more than half of all Americans will belong to an ethnic group other than non-Hispanic whites. The importance of mental health and minority care is to understand who we live amongst, who we serve, and to be able to destigmatize these factors that inhibit people from engaging, utilizing, help-seeking behaviors and resources that they're eligible for and that they should be receiving. So the importance of minority mental health. It's important to understand, again, who you serve, who you live amongst, and also those that you may engage with. And so it's so important for me to share some statistics with you, specifically around African Americans or people who identify as Black. African Americans may seek care. However, when they do seek care, they often receive poor quality of care and experience a lack of access to culturally competent care. And compared to the rest of the population, African Americans are less likely to be offered evidence-based medication therapy or even psychotherapy. And amongst those disparities, Black individuals with mental health conditions such as schizophrenia or bipolar disorders or other psychosis are more likely to be incarcerated than they are to receive mental health care. So why are these statistics so high when mental health care can be found everywhere? That's because there are disparities. Let's talk about them. The first one we have listed are social determinants of health, and that's just a pretty word to say, or pretty words to say that these are disparities, these are barriers that individuals face when they are born, they grow, live, work, or they're at an age where that influences their health outcomes. These determinant factors can include their socioeconomic status, their income, their education level, their employment status, and other access to resources. Additionally, we have to consider their physical environment. What does the quality of their housing look like? Are they living in safe developmental areas? What about access to safe and healthy living conditions? Are there any exposure to environmental hazards? What do their social support networks look like, such as family and friends and their community resources? Are they encouraging them and encouraging healthy help-seeking behaviors? We're going to follow up with the access to healthcare. Is the healthcare available? Is it affordable? And then is it quality healthcare? If you look at social determinants of health related to education and literacy, what is the level of education that this person has attained in their health literacy? Do they understand what mental health is? Do they understand the signs and symptoms to look for? And do they know where to turn when they do have an emergency, or they know someone who may have an emergency or a mental health emergency? What about the neighborhood? Is it built and equipped to access healthy, nutritious food? Is transportation an issue? Or what about cultural factors such as beliefs, values, and norms that influence help-seeking behavior? Within the African American community, it is heavily relied on spiritual factors. So instead of going to a mental health professional, they would rather seek someone within their church, such as a pastor or a friend or a colleague that they are able to fellowship and worship together with. During my dissertation study, I did research working with LPCs who collaborated with African American pastors who received referrals from this population. And during this time, African American pastors stated that they felt that their relationship with the members in their church was more important than their understanding of any type of mental health disorder, meaning that they would rather serve someone with a mental health concern rather than refer them out for treatment. Again, this falls into other disparities such as systemic racism and historical trauma. Concerns such as slavery, the civil rights movement, or the Tuskegee syphilis study has created mistrust of professionals and help-seeking behaviors. We then have poverty and discrimination, lack of cultural competent care. With poverty, discrimination, and the lack of this care, it creates significant barriers to mental health for African Americans. Poverty limits access to essential resources, while discrimination leads to chronic stress and mental health issues, and a lack of culturally competency prevents many of them from seeking help. By being able to address these challenges, it requires us to combat systemic inequalities, being able to increase access to culturally sensitive mental health services, and also be able to deliver diversity in the mental health workforce. That means we need to be able to see and work with individuals who look and have similar backgrounds. So how do we develop a culturally competent healthcare systems for marginalized populations? It really is quite easy. In order to do this, create community-based services, bringing mental health care directly into minority and marginalized communities through accessible and culturally relevant programs. Being able to train mental health professionals to better understand and serve minority clients and the unique needs that we present with. Creating peer support groups, utilizing peer extenders and peer support workers provide this community with the opportunity to understand that there are mentorships available, and it also reduces stigma and fosters a connection between professional services and the community that they serve in. Utilizing telehealth and technology is also an access for this point. It offers culturally tailored mental health supports through platforms and mobile devices, whereas they may have transportation issues and unable to go into the community in which they live. Providing a trauma-informed care helps you be able to recognize and address the impact of trauma, including historical and racial trauma that impact minority mental health. And then you have that advocacy, advocating for policies and systemic changes to improve access, to improve funding, and the quality of care within minority communities. And then having equitable access to mental health services and resources, going into the community, collaborating with the strengths and the support systems of the Black community, such as churches, such as community organizations that meet the need of this population on a daily and historical basis. And being able to destigmatize help-seeking behaviors. And instead of people saying, well, why don't you pray about it? Helping them understand that you can have Jesus and you can have a therapist as well. So being able to work in your community, provide a need, provide a service that addresses these needs, and then go further and foster those connections. By being able to create culturally competent minority mental health care involves training mental health professionals to understand and to respect the uniqueness of our cultural backgrounds, our beliefs, and our experiences as individuals. It also includes developing services and interventions that are tailored to meet our specific needs and preferences of having a diverse community, and ultimately aiming to improve the access, the effectiveness, and the outcomes in mental health care for minority populations. Thank you so much for this opportunity to share space with you and to discuss minority health care. Next, we are going to introduce Carolina Abuelo, the Partners Access Manager. Thank you.
Good afternoon. I'm Carolina Abello, and I'm native from Argentina. I am the manager of Partners Access Call Center, and I will share with you information about our Latino culture that is in North Carolina. So I will start, and I'm a licensed addiction specialist. I'm a certified supervisor, and I have about 30 years providing services in the North Carolina area. I've worked most of my jobs solely with Latinos in the half of my career. So over the years, I've done a lot of speaking appearances, just sharing how do we provide better services for Latinos and what are the different barriers that we have and things that we still need to develop in our behavioral health services in the area. The first thing that I'm going to cover is the terms. Sometimes we see Hispanic is a term that the government has used a lot, but it's not the same as a person who's Latino, Latina. So Latino, Latina, you are native from Latin America, and Hispanic, pretty much you speak Spanish, but you can have somebody who's from Spain, they're Hispanic, but they're not Latino. And somebody from Colombia, they're Latino and Hispanic, right? Somebody from Brazil, they are not Hispanic. They speak Portuguese. They were colonized by Portugal, but they're Latinos. So it is confusing. So just know that there is a difference. There's also the term Latine, and it's for gender neutral for our LGBTQI population. And the younger generations also identify with Latine. They also use the Latinx. Either though when you look at some studies, the Latinx hasn't been as accepted that much because the X in mathematics is a like invalid neutral term, and so like an impossibility marker within mathematics. So it has some criticism, the Latinx term. So just a little bit about the term. So just know that there are different meanings. So just giving you a visual of all of the countries that involve Latin America. We're talking Central America, and North America, South America, of course, Mexico is the one that lingers with us. So above Mexico is the US, and then the islands. So lots of different countries that are considered part of Latin America. So why do we come to North Carolina? And I say we because I consider myself an immigrant. I'm a naturalized U.S. citizen, but I definitely came as an immigrant from Argentina, and I had to go through my whole process. So it's something that is very present in my life story. So it can be because of economic fallouts, world pandemics. The U.S. agriculture system has over the years brought a lot of working visas because of shortages in the labor in our agricultural agricultural work departments. Natural disasters, medical treatments, colleges and universities, and other survival reasons. For example, I came for political reasons in a way. I had a mother who was a judge, a federal judge. She was a criminal judge, and we were persecuted and with lots of threats and kidnapping. So I got my degree and left. So there's also reunification of families, marriage, and so many reasons why we see. It's very important that when you're serving anybody, or if you're listening to me and you're a person who's seeking service, you're a Latino, to sometimes share where is it that you came from and why did you come from, because it's connected to maybe some of the reasons why you're seeking different services. So these are some of the immigration categories. Somebody who's like myself right now, I'm a naturalized US citizen, but initially I came and I switched into a working visa. I was in an employment, I had a student visa and then switched to a working visa. Then I became a natural US citizen throughout my process. So, but you have refugees, asylees, temporary protected status. This is mainly El Salvador, Honduras, and Nicaragua. It's connected to relief with climate and hurricane disasters. So, and these are the refugees. This section right here is the refugees of arrivals in Latin America. So historically, there was not a lot of Latin American countries that were taken within the refugee program, but right now we do have several. Cuba no longer has refugee status right now. It used to be that a person from Cuba can cross and automatically is received, but now they have to go through a refugee program. Colombia, Honduras, Guatemala, and El Salvador. So what's the difference between refugee and asylee? A person who's a refugee starts the process from their native country or from a neighboring country that is receiving them before they come into the US. And the asylee arrives at the US at the port of entry. So that's pretty much the difference. So the refugee is usually outside the United States when they're screened for the resettlement, and the asylee, they're crossing and they're asking for asylum. Generally, you hear the term political asylum. So refugee countries right now, Colombia, Venezuela, Guatemala, Cuba, and asylum, you see Venezuela, you've seen probably in the news, large caravans of different persons from Venezuela. They are resettling in North Carolina. I've been to several restaurants that I can hear the accents, and I always ask them, oh, ¿de dónde es usted? Where are you from? And they say Venezuela. And I ask, how long you been here? Oh, I've been here for 2 months. So, you can hear their excitement, their nervousness, and So there are countries in a lot of devastation financially, but you also see Guatemala, Honduras, Mexico, and Salvador. So asking is always helpful because then you understand what's bringing them to the U.S. and what have they been through, right? What is it that they've been, is connected to possibly some trauma. The Medicaid expansion, it's important for the Latino community because it has, increased the number of families that before did not qualify for Medicaid, and now they do because the different parameters of financial income in the house has changed. So this is bringing gaps for different Latinos who are in the U.S. Latinos with limited knowledge, sometimes they don't, of limited knowledge of the different access that they have to health or the different benefits. So it's important to call your plan, whatever LME you have, and find out what are the services that you have, right? Asking also the different providers that you have to give you information in your own language. I was in a call this morning as part of the call center, and this person was not with partners, but they were receiving everything in English, and they were like almost like in tears on the phone, like I can't understand anything they've sent me, and the stress of that, right? To have this whole package of information that seems very important about your health, and they can't read it. So make sure that you ask for the information in Spanish. That's what, and if you're a provider, make sure you have that available as well. So the documented immigrants was a new population that this is from last year, but it's also important because before in the history of Medicaid, we didn't have that. And it's for any Latino who's a permanent resident who has been granted asylum or is a refugee, has been granted withholding of deportation or granted conditional entry. So basically a lot of Latinos who are either in the legal situation, but also in a process with immigration, but is still in a legal documented standing, right? So that's the population that entered Medicaid benefits, and we didn't have before. Exceptions to this documentation is anybody who's a victim of domestic violence. There's special exceptions for domestic violence. There are exceptions for trafficking victims. So if you are in any of those two populations, just find out what is it that Medicaid can do for you, because there are exceptions to these populations to protect them. So anybody that's in this two, domestic violence or human trafficking, there are victims exceptions to access Medicaid services. So I would say different country, different trauma. So don't assume that all Latinos have gang trauma, or all Latinos have financial trauma, or all Latinos have trauma because they crossed the border. Every story is a very unique story. And the one thing that we have in common is that being an immigrant, you will have some sort of trauma. I think immigrants come to play tourism to the US. Like, it didn't occur to me like, oh, let me go see Disney World and let me stay by the way. It doesn't work like that. If you're an immigrant, you're going to have some pre-immigration trauma, you're going to have some during migration trauma, and post-immigration trauma. So if you are, like I said, a Latino that's listening to me, it's so important to find out, and process what happened to us. I think that sometimes as immigrants, we start working and we push all that down, and somehow it comes out in different ways. So part of our health as immigrants and productive immigrants and contributing immigrants is understanding what happened and how do we contribute and to process what took place. So just if you're a provider, just making sure that the story. The story is so valuable, it's so important. So don't assume And also look at his first generation, second generation. I have children that are first generation, and they describe their own trauma just because their mama is Argentina, is Latina, and like they were raised with no peanut butter. That's a trauma for them. They're like, my mom never gave me peanut butter. There's no peanut butter in Argentina, so yeah, I never gave it to them. So just don't assume that is the same trauma for all. We do have what is called migratory grief, and that is about having to relocate geographically and having that intense sense of grief, of loss of familiar places, or of course of your family. You first go through a denial or kind of anger, functional shock, trying to, you go through resentment, you go through guilt and pain. So a lot of triggers for this are going to be holidays or special days. Like I had my mother's birthday on Sunday, and I was looking for empanada dough and I couldn't find it anywhere. So I improvised. So all those things happen all the time to immigrants. We have special days, special holidays that are harder, and that we need a little help throughout those times. I think depression is one of the main diagnoses for immigrants, as well as PTSD. We do go through a lot of losses and what we call core losses. So loss of loved ones, loss of language, loss of geographical references, change in your social and legal status, the demand of the new culture, the loss of belonging, physical and psychological risk. When different Latinos go through a lot of stressors in the beginning of their process as they're settling in the new country. So a lot of stress and anxiety and fear of what's going to happen to me. I'm going to be deported. I'm going to be sent back. Is it going to work? Is it not going to work? But the stress of being in a country that a lot of things are very unfamiliar. Si yo, por ejemplo, me pongo a hablar en español y me cambio, y capaz algunos de ustedes hablan español y entienden lo que estoy diciendo, pero la mayoría de la audiencia no me está entendiendo. Y capaz se sienten incómodas, se sienten con ansiedad, pero eso es lo que le pasa a un latino las 24 horas del día. So I just switched to Spanish. So you maybe felt a little bit anxious for, it was less than a minute. I don't know how many seconds I did. But however you feel, you were like, oh, did she realize she switched to Spanish? Is she going to switch back? Just think that that's what a Latino goes through 24/7. If you ever travel, maybe it has happened to you, but imagine going through that every day. So the culture shock is also being immersed in the system that is, and right now that's why you see neighborhoods as there's a lot of Latinos, or they're in their own little subculture with their Latino radio and their Latino TV, or of course you got Netflix in Spanish. So there's a lot of things that you can do to help the cultural shock. Back in my days when I first came, that was not a lot there. So you were even more immersed and it was a lot more stressful. Latinas who come with the language, of course, have a little bit less stress because they know the language. That's obviously, and that happens to a lot of Latinos, and maybe they do come with a language. So why are Latinos not receiving only 2%? It shows that they're receiving mental health, services. So lack of knowledge of the services, sometimes with the culture. We come from countries maybe that it was either not promoted or there was not a lot of services that the government provides. Not part of the culture to go. It depends if you're coming from a big city, if you're in a rural area, so making sure that you can remove all of those barriers, giving information about what services we have, removing the fear of agencies and governmental agencies with undocumented status of members. If I have somebody on the phone and I have to ask about their documentation, I make sure that I tell them, this is just to make sure that I know how to help you. Like I'm not, I'm not connected to, I'm not reporting anything to the government. It's just to know how can I help you better, to find out which providers have sliding fee scales and use state funding for crisis. The state funded for crisis is used for undocumented Latinos as well. Make sure that you check in. Make sure that you check in your ethnic and racial prejudice. So if you grew up with any of that, you have to make sure that you become aware so that you don't hurt anybody's feelings. Sometimes for services, like Simone mentioned, faith and religion could be a barrier, going to the priest versus seeking the proper, behavioral health service, or maybe they're in need of medication. So how can we marry the two and make peace with both is also very important through education. And Latinos need all the time information about their rights, about their services, and to make sure they can have access to mental health services regardless of their legal status. Best practices. So what are some things that we should do, or if you're a Latino, that you need to make sure that you find? Being able to find bilingual providers. So using translation services is good for a very short time. But if every time you're trying to do a treatment and you're having to have a translator, it's not the same. There is a gap. So having bilingual staff is important, having bilingual support staff, having forms that are double-sided bilingual, like you're receiving information in the mail that is in Spanish. If you go to a provider and in the lobby you don't see anything in Spanish, what is the message that we're sending when that happens? So make sure that the front lobby, when you go to your clinic, that you have things that are for you. And if not, you should mention it to the receptionist or ask for the office administrative person. And of course, sometimes we have to have special help for anybody who's not able to read in either language, and make sure that we can assist them as well. What is not recommended is using a family member as an interpreter. So if you are a provider or you're a family, just know that using children or family members is highly, highly not recommended. It disturbs the family dynamics. It violates HIPAA law. It is inefficient, and the only time that it would be like a life and death situation. I know that I've trained Charlotte Police Department back in the days, long time ago, before they had a whole unit for Latinos, and they would use family member when it was completely life and death. If not, they wanted to use interpreters, and then they started develop their own bilingual team. But there's a lot of missing information and uncomfortable for whoever the family. Like if I'm a dad and I'm trying to get help for substance use disorder, and I'm having to share things to my daughter about my own substance use disorder, that is a very uncomfortable, not recommended practice at all. Make sure your voicemail has a bilingual message. And I think that's kind of a summary in a way of what are some things that we see with the Latino community that we can make sure that we address when we are serving them. I put in this last slide our member service line, our partners crisis line, and the provider service line. This is for providers. And sometimes if you're a provider and you have somebody in your office, you need to consult us for any Latinos issues, make sure you call us as well. And so thank you for allowing me to, I know that I went kind of Speedy Gonzalez way, but thank you for allowing me to share, and I will send it back to Beth.
Thank you so much. All right. I am going to open it up for questions. If you have a question, please feel free to to raise your hand and I can open your mic, or you can type it into the Q&A and we will answer. I just want to say thank you again to Brittany and Simone and Carolina for giving us their time and expertise in their presentations. Currently, we don't have any questions. So please feel free to raise your hand and I will open your mic or put it into the Q&A. And if we have no questions, I am going to introduce Sasha Bonner, and she is going to share more information about partners.
Good afternoon, everyone. I'm going to just touch on some little tidbits about partners. As I want to first thank everyone, all the panelists, for being here. It was some great topics. I was taking notes myself. As you know, Partners, we are a managed care organization here in North Carolina, and we provide services for our members that we serve within our catchment area. We're considered an insurance plan. You know, we want to make sure that we offer resources. We don't actually provide the actual services and supports, but we will offer the resources and make sure we get you to the right direction. You can go on to slide number 4. Yes, I'm going to touch a little bit about Member Connect, which is our member portal. And it is a very, very helpful tool that you can utilize in order to maintain and understand your services and resources. You can go on to slide 5. Perfect. So with Member Connect, with our portal, you can review your documents. You can look at your ISPs, as well as your PCPs, look at some of your benefits and what you may be eligible for. You can look at some member resources as well, some tools to help you keep track of those, maybe appointments or whatever type of screenings that you have coming up, your rights and responsibilities. It's a plethora of resources and a great tool to look at once you get connected. As well as with that PCP, you can also request to change your PCP if needed through our Member Connect through your portal. And we can go to slide 11. All right, so right on to slide 11. Again, this is our member and recipient call lines. These are very important numbers, as well as a great resource to access assistance or care when needed. Partners Behavioral Health Crisis Line is open 24 hours a day, 7 days a week. Calls are answered by licensed clinicians and immediately triaged. You will be connected to mobile crisis if needed, and that will be identified through that clinician. Member and recipient services is open Monday through Saturday from 7 a.m. to 6 p.m. That member and recipient service line is 1-888-235-4673, as well as Kimberly is dropping those numbers in the chat for you as well. Our crisis line, 833-353-2093. And provider services, we have 877-398-4145. And we can go on to slide 13. You're right on it, Beth. Thank you. It is important to stay in touch with us. Please keep your contact information updated, as we may need to contact you about your health plan. And we want to make sure that is really, really important, because if we have some pertinent information that needs to get out to you, we want to make sure it gets to you. And we don't want it to get lost, and we don't want you to get lost in the shuffle. So that's the most important thing. If you have Medicaid, you can call your local Department of Social Services to update your address or phone number. Department of Social Services shares that information with partners and other MCOs on a regular basis. They also may need to contact you for by mail or by phone. So that's very important to keep that information up to date. If you're receiving state-funded services, please contact your local managed care organization or give us a call here at Partners through our member and recipient service, which is a partner access line That's that 888-235-4673 number. So what's very, we can go to the next slide of 14. Perfect. What is this is very important too. We want you to be in the know and to stay connected with us. We have trainings coming up. We have cafes. We have a lot of information that may come up, and we want you to be in the know. So you see the QR code. You can either hover over the QR code and register or subscribe, or you can subscribe on the website. And Kimberly will drop that in the link as well. The link in the chat box as well. And that's www.partnersbhm.org/subscribe/. And next, which is also very important, our feedback. We want your feedback. We want to know what it is that we're doing, good, bad, or indifferent. We like the good, but we have to do the bad as well. Or any suggestions that you may have. If you have any suggestions of any topics or anything that we can do differently, please, please, please complete this survey. The link has been dropped into the chat box, and we want to know how we can be better for our future sessions and what we can do to improve our presentations. And again, like I said, topics that may interest you. And that's that link right there. Or if you want, you can hover over with your camera as well, with your smartphone, and that will take you to the QR code would take you directly to the survey. That survey is very important for us because we want to make sure that we're meeting your needs. And with that, I want to thank you for attending our member cafe and donating your time to us. We greatly appreciate it, and we appreciate you and your support. And you can reach us by the member engagement department by sending an email to memberquestions@partnersbhm.org. And again, leaving that feedback on that survey is very important to us and for you. So we'll see you next month for our next member cafe.